Thank you, everybody that is joining us both online and here in the room. This is the third of our dissemination and implementation science workshops that we've been doing here for the Utah CTSI. Today, we're going to talk about outcomes in dissemination and implementation research. And if you want to save the dates, I also wanted to let you know that we will be doing, we're going to do, I think, 3 of these a year is our typical thing, maybe 4. The next one will be dissemination implementation strategies that Dr. James Merle and JD Smith, I think, are the folks that will be leading that one. And then we'll do one, and that's in October 17th. So if folks want to save that date, we'll be sending something out to people as well. And then the next one after that will be in January 2026, where we'll focus on community engagement and dissemination and implementation science. And I'm not sure who of our group's going to do that one yet, but we'll let you know. So today we're going to do the outcomes in dissemination implementation research, as I said before, and it's myself, Paul Estabrooks, and my good colleague, Dr. Shanuade. I always stumble over his name, but I call him Toby all the time. So I'm sure he's fine with Dr. Shanuade. And so we're going to go through a few different things today, but we wanted to just give you a little bit of context for where we're kind of grounding ourselves. And so this is one of the definitions that we used in our introductory workshop about 6 months ago, and then in our last workshop that Dr. Sloss and I did together, focused on theories, models, and frameworks. We're really looking at dissemination science as the dissemination implementation science as a scientific study of the strategies and mechanisms by which scientific evidence is disseminated and implemented in community or clinical settings to improve outcomes for a specified population. Okay, so we're going to do that. As I mentioned last time, we talked a lot about theories, models, and frameworks. I always like to throw up the old faithful diffusions of innovations up there. Still one of my favorite theories to use. We're not going to talk a lot about theory today, but you will see when we get to some of the parts of the workshop today where we're talking about developing strategies for a specific outcome, we will walk through mechanisms there. We won't really get into a lot of detail about which theories we're pulling our mechanisms from. We'll just talk offhand about that. Although all of the projects that we're presenting today are theoretically based. So we're going to start with dissemination implementation outcomes. A couple of different theories. How many people have heard about REAIM before? Raise your hand if you have. Let's see, I'm trying to look online, see if we're getting some hands raised. Okay, thank you, Sandra, for raising your hand for us. Yes, so we're getting some hands raised. How about Proctor's implementation outcomes framework? Okay, a little bit less knowledge of that one here, but also a very popular and highly utilized framework in dissemination implementation science. We're going to talk a little bit about both of these, but we're going to jump in first with an activity. Since last time we did our activity at the end and all our online people bailed out, we decided to catch you this time and get you right at the front end. We will have some breakout rooms for the folks online with some facilitators here. So and it's fun. It's going to be good. So Toby and I are going to do this together. But the activity that we're going to do is, if I can get my slides to move forward, we're going to walk through some hypothetical, loosely based in reality weight loss program data. And that's some of the work that I do and some of the work that Toby does as well, although his work is a little bit more in cardiovascular disease risk explicitly. But I want you all to get a pen, piece of paper, or in your computer, you can type these things up. We're going to give you information about outcomes of these programs. We're going to let you ask a question or two, but we're not going to give you a lot of answers outside of the data that we're presenting here. So you can ask some clarifying questions, but don't ask us a lot about the programs or things like that, because we're not going to tell you. We're just going to have you focus just on the outcomes. And so we're going to do, across these outcomes, we're going to have you rate each of the programs from a 1 with a low rating to 5, a very positive or high rating, each of the outcomes that we talk through for each of the programs. At the very end, I'm going to make you create a graph just so that you know that. Okay, so the first information we're giving you about these 2 different weight loss programs is that weight loss program A produces an average of 10 to 15% weight loss. Program B produces an average of 3 to 5% weight loss. So what I want you to do is say which program's better, and then rate each program from 1 to 5. Okay, so go ahead and write that down. Online, I hope you guys are doing this too. Oh, we have our first person. I'm not sure I have it up. Okay. Okay, just based on these effectiveness data. Yeah, that one, I'm not giving you more outcome data. Uh-oh. Who can give me an answer? Based on these data, which program is better? All right, JD Smith, you know, he's very shy. He doesn't like to respond, but he was the first one. Yes. Okay, he thought that program 1 is better. So we're going to move it along. Toby's going to take you through the next one.
Yeah, so for the second program, it's going to be on REACH. Program 1 focus on 5,000 community members, 3,000 eligibles, and 200 people participated. All of this from low income, underserved populations. And program 2 include 5,000 community members, 3,000 eligibles, 600 participated, and include 20% from low income, underserved populations. So right then, which program is better? Which one was able to reach more people? And rate each program on a 5-point scale, 1 being the lowest and 5 highest.
And we don't want you to think back to the effectiveness data.
Yeah.
Just the reach data. Just what we presented you. So go ahead, rate those numbers.
Okay. So anyone with which program is better based on this information?
We're going to watch, we should watch the. Oh, that's a really good question that we're not going to answer. So we're getting stuff online too. We're getting some, depends on who you're wanting to reach. Yes, this seems to be a very consistent question.
Yeah.
We're not going to tell you. You just decide. What do you think? It probably does depend, right? It probably does depend on who you're intending to reach and benefit from your intervention. Okay. So what do people think? Did we hear an answer? Program 2. How many people say program 2? In the room, we're getting about a 50-60% response for program 2. Okay. All right.
Okay.
I'll jump over. And Liz, I'll get you to monitor the chat if there's anything for us to respond to there. Okay, so I get to then talk about the adoption. So for program 1, there was 200 communities that were eligible to deliver the weight loss program or adopt it and use it. 20 communities of those 200 were approached to participate in the first program, and 25% of those communities agreed to participate. In program 2, all 200 eligible programs, was that the owl hooting at me? You guys online didn't hear the owl hooting at us in the room. For program 2, all of the communities were approached to participate and 50% decided to deliver. So write down your rating of adoption for each of the programs. 1 low, 5 high. Use your own personal grounding for how you want to rate those programs. I could tell this one's better because people are squinting at the screen and reading and thinking through. Ooh, Kathy Maxwell. Program 2, a rating of 4. Okay. Oh, I like that you're sharing your rating too. Yeah, I've got to admit, I was doing this program and we got 50% of all the communities to agree to participate, I'd be pretty thrilled too. I might even go above a 4, but you know. Okay.
Yeah.
Okay, which one's better? Did we say? Yeah, good. Everyone said, everyone jumped on board with Kathy and Angie. All right. Toby, go ahead. Oh, I'm trying to get it to advance for you.
Yeah,
I'll let you do it. It's not doing it.
okay, yeah. So the next one is on implementation. This is more or less pretty straightforward, I think. So for program one, the program was delivered with 75% fidelity. That is 75% of the intervention was delivered as intended. And for program two, it was delivered with 95% fidelity. That is 95% of the intervention was delivered as intended. So write on your ratings, 1 low, 5 high. So which one has higher fidelity based on this information?
Okay, so I'm looking at all these.
We're right now, though, we're asking.
Yeah,
just
independent
for
of-
this piece of
yeah.
data.
Just
Mhm.
looking about this.
Yep. Yep.
So the other one, what do we think? 2, 2, 2. Okay, program 2. Anyone? Like?
Pretty good.
Nobody. Okay.
Yeah.
Yeah, excellent.
Great, thanks, Toby. Yeah, we did hear some comments that 75% implementation facility is still pretty darn good. Okay. This is maintenance at the participant level. Okay, so you saw the weight loss that they had in effectiveness, but I don't want you to think about that right now. What I want you to think about is that the participants in program 1, 75% of them maintained 10% weight loss. Program 2, 50% maintained 5% weight loss. One question we usually get, and maybe it's just that people in this room know, is like, what's a clinically meaningful magnitude of weight loss? And so everyone knows 3% really good for prevention of cardiovascular diseases, 5 to 7% really good for diabetes prevention, 10% and above really good for all of that general health promotion and typically weight loss maintenance as well. I guess that's what it is, weight loss maintenance. Okay. I don't know. I would say what I would say. So the question in the room was, what happened to the others? Did they rebound and have, terrible weight regain? And we're going to say no. We're going to say that they just didn't maintain the weight loss on average that was achieved. It's a good question. Okay, so what do we think? Which one of these ones is better? Program 1, we're seeing a very universal agreement around program 1. Okay, online, yep, we got program 1. Kathy jumped right in there. Good work. Oh, so that dealio out. All right, so and remember, be rating them 1 to 5 each. Okay, do that as well. And then I'll give it back to Toby.
Yeah, thanks, Paul. So this is still maintenance, but at the community level instead of participant level. So for program 1, 80% of the communities maintained program implementation for a second year. And for program 2, 50% of the communities maintained that for a second year. So remember, this is at a organization level, community level. So which program is better based on this information? Okay, we have Cardi said program 1. Okay. program one, program one. Do you have consensus?
Looks like I saw a lot of.
Yeah, a lot of one. Okay. This is great. So let me hand it over to you, Paul.
All right, great. Okay. So here's what we're going to do next. You're going to draw a graph. You're going to have the reaim dimensions on the x-axis, and your y-axis will be your ratings. You're going to label it as program A and program B. You're going to take a picture of that. You could do it with your camera. You could do it with a screenshot, and you're going to email it to me. And you can see where that is. I used to try and turn these around in real time. It takes a little bit too much time for this type of workshop, but know that your ratings will be shared with others. So if you really don't want to share it, you don't have to, but I think now I've got somewhere close to 80 of these different little graphs that, and at some point I'm going to content analyze them, see what it looks like. Okay, so you're going to do that. And so once you've done that, we're going to shift to, and I'll pop back to here in case folks need the email address still. But after that, this is where we're going to get into some small groups. And so probably groups about 4 or 5 in the room, and online we'll do the same thing. And so we'll probably make like 3 groups online that we'll separate folks into, and you're going to review the data, and together you're going to agree collaboratively based upon all of the data which program is better. And once you've done that, you're also going to come up with the 3 most pressing questions that you had that you think really would have made it easier to decide which program was better. Okay. All right. So I'll put that back up, and folks in the room, as you start to, actually people online too, as you start to finish your graph, just give me a little thumbs up so that I know it's done.
You need the information of the next slide.
Oh, they go to the next slide now. Yeah. Hey, Megan, glad that you joined. We're just in the midst of a little activity. So you'll get grouped into a small online group here in a moment, and your teammates will fill you in on what we've done.
Sounds good, thank you.
And it's nice to see you here. You know what? I'll put my email in the chat.
Oh, yeah.
Say that one more time.
Not everyone in the room is on Zoom.
I don't know what that. Oh, I see.
People were still.
I'm like, so what does that mean? I guess it means I wouldn't be able to see my email. Are there people in the room that aren't of you? Because if you are, then just type in my name and it'll pop up.
Yeah.
Okay, how are folks doing on their graphs? My CCET people, you guys good? Okay, great. All right, so why don't we... Great. So we'll do the breakout rooms, and I think what I'll do is I'll mute my microphone up here, and then folks online can talk amongst themselves. And I think Kayla, Shannon, and you, Juan, are you going to jump into one of them? Just 2 groups? Okay, great. We'll do 2 groups online. Kayla and Shannon can facilitate those. All right, and I think we'll probably, based on where we are timing wise, I think we're in pretty good shape, right? So we'll give about 10 minutes for folks to do that. Okay, 10, maybe 15. Okay, great, folks. I think we will pull people back together. Toby, we're going to use the owl now. I think that's where the volume is. You have a very important but soft voice. Over here. Okay, let's just start. First of all, each group tell us which program was the better program. Definitively. No,
Pick one,
we have,
and we will argue that.
It wasn't very definitive.
okay, we got one vote for one. One vote for two.
Ours, they will pick two.
2 votes for two. 2 votes for one, 3 votes for one. Is that as many groups as we have? 5? We have 2 online
Yeah.
and 1, 2, 3 in here. That's right. Okay, great. So, nice split. A nice split. Okay, so, and we're not going to get report out from every group, but if you feel like the burning desire to talk and you're online, unmute and talk, and we should be able to hear you on the owl here. But let's first hear the defense for program 1.
I'm gonna take it. We said one was the better program because in reach and specifically mentioned underserved populations. And so I assume since you're mentioning that, since you're measuring that, that is a target population. The average weight loss was better according to your scale of blood matters, clinically significant weight loss. And fidelity was lower. I mean, the adoption was a little less and fidelity was a little less, but overall the maintenance was good for this, what we assume is an at-risk population.
Okay, great. So heavy emphasis for the group 1 around getting this to populations that probably don't typically get this type of thing and being able to have really good outcomes with that population. Okay, fair. Okay, well then why is program 2 better?
I think program 2 is better because, if you want to know about the effectiveness of a program, we thought it was helpful to have a diverse, more diverse sample with like higher uptake amongst the groups that you're trying to reach. And like evidence that the program can be administered with better adoption and fidelity. Just, thinking about like actually implementing this in the real world afterwards. And we felt that the maintenance numbers and community numbers were good. Maybe they weren't quite as good as program 1, but in a more diverse sample, it may actually be more representative of like what you can expect. So even though the effectiveness, for example, was more effective in program 1, that may not be reflective of what the real world effectiveness is because you're kind of studying it in a pretty select group. And so that's why we thought program 2 is probably better, or program 2 is better.
Okay. And one of the things I hear when we've done this in other groups, and I feel like I've heard it a bit today too, is there's always this discussion around groups that experience disparities or inequities and wanting to make sure that we're doing things that don't exacerbate that for one, but even better than that, advance equity or health equity. And so we hear that a lot. And it's clearly one of the reasons that we put the thing together the way that we have. The other thing that we tend to hear is a little bit of a focus on individual re-aim outcomes when you think about program 1, and then more of a focus on what I would consider more of the aim of the re-aim side of things, but also the dissemination from a reach perspective tends to be. So those things are pretty typical areas of discussion. So let's move now to each group. I want to hear the top priority question you had that would have helped you to make you feel really good about your decision. And I'm going to even increase the stakes. If your top question gets asked before you, I want you to move to your next question. Okay. All right, I'm gonna start from this side first.
All three questions?
Just one,
Just one.
your top one.
How are we weighting the re-aim elements?
Okay, that's a really good question. How are we weighting the re-aim elements? What do you guys think would be a good answer for that? It depends. Yeah, has anyone ever done a workshop with Russ Glasgow? He loves that answer. He has it like on 10 slides. It depends after each one, but it does depend. And, you know, and so how are you prioritizing different dimensions? And that's typically about where your research practice gap is and where your priority population's priorities are, right? So that's a really good first question. Okay, I'm gonna go to one of the online groups and somebody can go ahead and unmute, or one of the folks.
We had a question, what is the cost of the program? Is there partnership buy-in? Is there staff FTEs? Are there other considerations?
Excellent, excellent. So cost of the program is a really important one as well. Clearly, if things are too costly, they're hard to sustain. Now, the one thing and so I think we kind of set it up that you should ask us about cost because we don't give you any information about cost. Now, implicitly, we talk about sustainability and maintenance. And if something's maintained, it implicitly makes you feel like, okay, they're getting value for what they're putting into it. But it really is good to know explicitly what's the cost, what's the budget impact of what we're doing here, what's the return on the budget that we put out. So those are all important questions. Okay, next group. Let's go.
I think our number one question was, you know, what setting was this study done in? So for example, was this an intervention that was intended to be rolled out like at QHCs, or, you know, like intended for a sort of resource limited population, or was it done in India where actually, you know, South Asian populations higher cardiovascular risk, right? But a very diverse group where you'd actually want a more diverse sample.
Yeah, yeah. So you really need the context of the needs, priorities of where you're working. Okay, you guys, one of the ones that we haven't asked.
One that I think we all resonate with was, what is the scalable unit for each of these programs?
Oh, I don't think I've heard that one. It was, what are the scalable units for this program? And I'm just gonna give you, we're not gonna go through all the ones up on the board. These are the ones that are the most consistent questions that we get. And I know we have one more online group to tell us, but you know, what is the scalable unit? I think that's a really good question too. Like, is it scalability within a given community context? Is it across community context? Do you have to have, what are the partnerships that are needed to get this thing into these communities? What were the facilitation strategies, all that kind of stuff? Yeah. And how do you scale all of that? Okay, last group, Shannon. Okay, Shannon has deferred to her group to someone to unmute and give us their question. It's very exciting for us to see if the owl works. Yeah.
This is Kathy. I'm from that group. I would ask, how important is the mechanism of the intervention? How should we consider the mechanism of the intervention?
Okay, give me a little more on that, Kathy.
So, you know, what is it about the intervention that's causing the change in weight loss? You know, what specifically about the intervention? It seems like that should be really important.
Is it healthy? You know, is it rapid weight loss? Is it done with some, you know, aligned with evidence and those types of things? Absolutely. Super important question. Okay, well, I think we're gonna move it along here. Thanks everybody for participating in that, and for our online folks for sticking around for the activity. That is excellent. We're gonna shift, I think, back up to here.
Do you want to go ahead and unmute?
And Toby's gonna do the next part of the workshop.
Okay. Thanks, Paul. Yeah, so I'm going to move to providing simple definitions of REHIM, and then provide examples from like one of my projects. And I hope, yeah, if you have questions, please feel free to stop me and I'm happy to provide a response to that. Okay, so the project I'm going to be talking about is called Hypertension Treatment in Nigeria. And this is a project that I was part of when I was at Northwestern University. Yeah, this is what we implemented for 4 years, and it's an R1 project. So we collaborated with NHLBI, Washington University. Actually, one of the PIs moved from Northwestern to WashU, and then University of Abuja, and Resolve to Save Life. So these are I'm trying to close this. So these are the two NPIs, Mark Hoffman at WashU and DK Orji, and they are both cardiologists who I work with. I still work with the two of them. So giving the kind of context to this project, so in Nigeria, 40% of Nigerian adults have hypertension, and 60% are aware of their hypertension status. 33, that's like 1/3, receive appropriate treatment, and 12.4% have controlled hypertension. So we could see like the gap between prevalence awareness, treatment, and treatment and control. So there's a gap we call that hypertension care cascade. And that is what we want to fill. So the aim or the purpose of HTN is to improve hypertension awareness, treatment, and control in Nigeria through the adaptation, implementation, and evaluation of the effectiveness and implementation of a system-level hypertension control program. So that's what we did. So the evidence-based intervention is a culturally and contextually adapted program, which was based on the Kaiser Bundle. The Kaiser Bundle is a multi-component hypertension program and has been shown to improve hypertension control. And this was also based on the WHO heart program, which was based on Kaiser Bundle. And this is what WHO recommend for Ministry of Health in different countries to treat cardiovascular disease. So this is the program that we adopted for our study. So this program has 7 components. The first one is hypertension patient registry and empanelment, which is providing real-time registration for patients and empanelment of hypertensive patients. So this is what we did for the first few months when we started the study. And the second one is performance and quality reporting, which was a monthly hypertension treatment control and retention report. So the community health workers provide monthly reports on treatment rate, control rate, and retention rate. The third one is team-based care and non-physician follow-up. So we trained community health workers to diagnose, treat, and manage hypertension among patients. Because of the context of where we implemented this, we needed to train the community health workers to be able to reach more population with hypertension. So the next one is access to essential medicines and technology. So we provided free medications to all the patients for some period, and you're going to see, and then we transition to something else called the Drug Revolving Fund. I'm going to explain that later on. And the next one is fixed dose combination. So we encourage promotion of the use of fixed dose combination. And the reason is this is one of the strategies that actually improve hypertension control. And the next one is simplified treatment guideline, which was based on the Nigerian hypertension guideline. So it's a 4-step treatment guideline. So if a patient is not controlled, they start with low dose medication. If it's not controlled, then they step up. If it's not controlled after a month, then they step up to 4. And this is based on the hypertension treatment guideline. And the last one was what we call health coaching and home blood pressure monitoring. So which we provided as additional strategy to lower blood pressure among those that have uncontrolled hypertension, even haven't gone through the 4 steps of treatment, and they are not controlled. So we introduced additional strategy for them. So our sample size was 60 primary healthcare centers in Abuja, which is the Federal Capital Territory. So 47 were from rural area and 13 from urban area. So in terms of timeline, we have the formative phase, which was in 2019. So what we did at the formative phase was conducted baseline quantitative service availability and qualitative assessment, studying the PhD staff to inform the adaptation of this intervention that we implemented. And the pre-implementation phase was in January to December 2020. So this was based on a sequential registration and empanelment of hypertensive patients at participating PHCs. And the implementation phase, which was from January 2021 to December 2023. So this is when we kind of implemented the full package, and we evaluated that. So I mentioned earlier on that for patients, we provided free medications for them up to a point. So from January 2021 to May 2022, they didn't pay for medications. It was provided for them. So to prime the drug revolving fund. So when we say drug revolving fund, it's kind of a model whereby you give the medication to patient at cost price, maybe plus markup. And the reason is to ensure that they have access to that medication and it's affordable in that sense. So from June 2022 to December, we developed the drug revolving fund through a seed stock that was funded by Resolve to Save Life. So patients pay a copay to cover the procurement of the medication and as well as administrative costs to sustain accessibility to BP lowering drugs. So the patient pay just the cost price. They didn't pay additional. And this is to make sure that they're able to afford the medication and they are able to adhere to their medication as well. So the drug revolving fund-based system emphasizes access to medication through reduced out-of-pocket costs. So that's what we wanted to eliminate. So we started with free medication, then moved to a period where they only pay cost price to improve affordability and also for them to begin to think about sustainability of that, of procuring medications. Okay, so our primary outcome, this is a hybrid type 2 study. So the primary effectiveness is changing treatment rate, which we define as use of any blood pressure lowering drug, as well as change in control rate, which is defined as systolic blood pressure less than 140 millimeters of mercury and diastolic BP less than 90 millimeters of mercury. So these are our primary effectiveness outcomes. And the implementation outcomes include, like we use REHIM, so reach effectiveness of this hypertension program. So I'm going to provide like brief baseline characteristics of this population. So the median age of the participant was 49 years, 4.4% have history of diabetes, less than 1% were current smokers, and the median BMI is 26.6, so many were like overweight. So in terms of hypertension status at first visit, we have 48.7% were aware of the hypertension, 65.2% were treating before we even, did our intervention, and 19.3% have controlled blood pressure. So I'm going to be moving to, talking about, just give a brief background about REHIM. So I provided a background about study. I'm going to be using examples from our study. So REHIM dimensions focus really on balancing external validity of efficacy trials as well as internal validity of effectiveness trial. And the essence is to maximize public health impact. So it has different elements. We have the dissemination outcomes, which is operationalized at the individual level. So we're talking about reach at the patient level, organization level. So we talk about adoption. So REHIM also has implementation outcomes, which is operationalized at the organization level. And Paul is going to talk more about this when it comes up. So that includes implementation, measuring implementation, and organization maintenance of that intervention. And we have the clinical outcomes, which is operationalized at the patient level mostly, and that focuses on effectiveness and maintenance. So what are the goals? So REHIM has 5 major goals. And the aim is to develop and test interventions that have the potential to reach a large and representative proportion of the intended audience. And number 2, to effectively improve and sustain positive health outcomes. Number 3, have high adoptability across a large representative proportion of the population. Number 4, can be consistently implemented with a high degree of fidelity. And number 5, can be sustained in typical clinical or community settings. So these are the 5 major goals of REHIM. So we're going to be moving to like the definition, simple definitions and examples. So when we talk about reach includes is the number, the percent of target audience and representativeness of those who participate or are exposed to an intervention. So that is what reach basically means. So how many people are exposed to this intervention? And we can see that based on the examples, the activity that we did earlier. So from our study, the total number of patients from the 60 primary healthcare centers that were eligible were 22,245. So number of those who agreed to participate were 21,922. So we have participation rate of 98.5%, which was pretty high in this population. So for the entire duration of the study, we have total number of patient visits, 142,493. So each patient had an average of 7 visits, which was it was a lot of work, but it was pretty good. Yeah. So let's move on.
Selling it, Toby.
Yeah, so we have 21,922 participants, 68.2% were women, 78.3% lived in rural areas, and 73.8% had lower than high school or below, which was a lot of, we wanted to reach more people that experience like health disparities. So we're able to reach like a proportion of women, those in rural areas, and those with like low level of education. So that is reach. So moving to effectiveness. So when we talk about effectiveness, it means change in, basically it's your intervention achieving the intended purpose. So change in primary outcomes and impacts or changes in quality of life and measuring any adverse outcomes. So that is measuring your effectiveness. So it's more on clinical outcomes. So for this study, so you could see before the intervention, before we started the implementation, the black, you can focus on that black. We experienced or we saw an increase in hypertension treatment rate from around 80-something%, like 86%. And by the end of the study, over 96% of people were on treatment. They were taking one form of medications or another. So for this implementation, this project, we saw increase in hypertension treatment rate. So when it comes to control rates, there was also increase from around 22% to over 50%, almost 60% were have blood pressure control, which was really, it was pretty good because when you look at literature in terms of what people could achieve within a space of 3 years, having this like significant achievement was good. So when you look at systolic blood pressure, there was a decrease in systolic blood pressure, decrease in diastolic blood pressure after the intervention. So these are all the effectiveness outcomes that we measured in this study. So going to adoption, what do we mean by adoption? So adoption means the number, the percent, and representativeness of staff, settings, organizations that agree to deliver the intervention. So with the HTN, so 60 eligible PHCs, 60 PHCs delivered the intervention. So the adoption rate was 100%. So all the PHCs were able to deliver that. Okay. So, and these 60 PHC also represent like the pattern of population in the entire community. We have more rural than urban. So this study has 78% of people from rural, or communities from rural PHCs. And yeah, so this was also representative of what we have in the entire community. So moving to adoption as well. So number of PHCs that used hypertension registry by 3 months. So when we start rolling that out, so all the PHCs they have their registry set up the first 3 months, which was good. And another thing was to promote, they are supposed to promote fixed dose combination therapy. So before implementation, 16.3% of the 60 PHCs were prescribing fixed dose combination or stocking fixed dose combination. So after the implementation, it moves to 49.6%. And at the end of the study end period, over 60%, like 65.2%, were have fixed dose combination therapy and using that and prescribing that to patient, which was good as well. Okay, so moving to implementation. So implementation is the extent to which a program or policy is delivered consistently. That's fidelity, and the time and cost of the program. This is pretty tiny, but this basically shows the number of 30-day doses of any blood pressure lowering drug in stock by area council. So all of them have some drug, 30-day doses of drug throughout the study period. And we could see the increase, the decline, but baseline, every one of them have 30-day stock in place, which was one of the things they are supposed to do as part of this program. And also moving on, so when we started, like 1,467 has 30-day doses of blood pressure medication. This moved up. After the implementation, this moved up as well. And when we transitioned to even drug revolving fund, which we could see in 2022, I don't know if you could see that. This moved up to over 53,000. And at the end, 2023, 78,000 has 30-day doses of NABP stock in their facility, which was what they're supposed to be doing, and they were able to do that. I'm going to switch a little bit. So for those that have uncontrolled blood pressure, so those with low education, and those who have gone through like step four treatment phase, no controlled blood pressure. So what we did was to give them additional health coaching and with own blood pressure monitoring. So what happened was the community health workers were trained how to do that. They provide training and they visit the patient every other week. So the study was for 12 weeks, 3 months. So they visit the patient every other week, spend time with them to ask them, okay, how are you doing? Providing health education, counseling about their diet, physical activity, using motivational interviewing. So they are not to tell them what to do. They're supposed to work with them to come up with, okay, this is what I want to achieve from this meeting. This is what I need. So the patient drove the discussion rather than the community health workers driving that discussion. So they do that. And what we also did was at visits 2 and 6, we recruited what we call the observers. So they observed what the community health workers were doing. Were they asking the right question? Were they, focusing on patient the way they are supposed to do? And so they're supposed to complete what we call the fidelity checklist. They do review personal goals, visit agenda. So they review that to see were they doing it as they should be doing that. We are still analyzing this data, but this just to show you this one way to kind of evaluate your fidelity using observation methods. So we couldn't have done like all the observers going for every visit. That was expensive. And so we just used visit 2 and the last visit for them to do that.
Toby, can you talk about why you picked visit 2 and visit 6 rather than maybe doing random visits?
Yeah, we wanted it to be consistent for all the PHCs, so that all of them know that visit 2, this is what they're doing. Visit 6, this is what they're doing. If it's random may also be good, but we may not be able to follow up properly with all the PHCs that we study. So we make it like consistent throughout. Yeah, thanks, Paul. Okay, when we talk about maintenance, as we said, maintenance, we have individual member targets. So we want to see what's the long-term effect, attrition of your intervention at the individual level. And we also have the extent to which that particular intervention is integrated into your settings or your organization. So for this study, we could see when we look at the baseline, like the number of people that are using medication or that were on treatment, 27%. But by the time we are done with this, like the study, you could see pretty much 96% were still treating their condition, which was pretty high. And I'm gonna show some other. So when we look at 6-month rolling period, so this is looking at retention rate, how many patients were we able to retain for 6 months continuously? And we could see, this red line shows the trend of patients that we're able to retain in treatment or in this study. And we could see throughout the entire study, like more than 50% were still in care in that sense. So this is a 6-month rolling average retention rate by implementation period, which is pretty reasonable and pretty high because we did some systematic review looking at like in retention rate, 5 retention. And this is pretty much, and JD was also part of that study. This is pretty much a high retention rate for the study. And when we look at 3, 6, 12-month retention rate, at 3 months, 56% were retained in care. 6 months, over 60% were still retained in care. 12 months, 64.4, and at the end of the study, 66% were still retained in care, which was pretty good. So the next phase is to see how do we maintain or sustain that, like long-term, to ensure that people are still in care. What strategies can we put in place to increase the number of people that are retained in care? So this is my part. So this is just going through the REAIM elements. I don't know if we have any questions. I'll be happy to take that. Shannon.
I was just curious, looking at the time frame of that, also, obviously, COVID
Yeah.
was within that whole part of the study. Do you think that you would have had different outcomes had it also not been for COVID, or did that not seem to be a factor in the implementation?
Yeah, great question. So I'm not sure COVID really affected recruitment. And also COVID was also a kind of positive thing in the sense that people rely more on primary healthcare system during COVID. Secondary, tertiary shut down, but people rely more on primary healthcare. So that may also have even helped the study for people really coming to using the primary healthcare rather than going like to secondary or tertiary. So yeah.
Your computer, I'm gonna turn on the owl so that.
Toby, I had a question about the structure of, first of all, this was really great. And I got a sneak peek at these slides when we were preparing this and, I held my questions to put you under the gun right here. But, one thing I wondered about was just the structure of the system that you were working with, that you got 60 out of 60 adopting primary healthcare centers. Like what's the overall kind of administrative structure? Is it something where if the top level says, this is what we're doing, everybody does it? Or was there more autonomy on the part of the community health centers?
Yeah, good question. So I will say that there are more autonomy. The way it's structured is that you're supposed to go to the primary care center. And if your hypertension is not managed properly, you will be referred to higher level like clinic in that place. However, the PHC has like autonomy. So once it reaches like 180, 150 refer. And the way we structure it, once they refer, they go with a letter from the PHC to the clinic they are going to. They already know we are doing the study. So once they refer them, it's easier for them to get treatment and also pretty much faster to get treatment. So the PHC has autonomy. Once they decide, they will refer to the higher level clinic.
Okay. And so that was really helpful. I was also thinking about, and I'll give you an example, like here, when we do school-based research, you're kind of at the will of each district. And even within the district, you're at the will of each school, if they want to participate or not. We've done work in schools in Mexico, and it's not the same there. If you get the district person on board, all schools in the district will participate. They don't really have the autonomy to opt in, opt out. And so I was thinking about like the 60 out of 60 community health centers. Is it because there's a centralized administrative decision maker?
Yeah. Yeah, a very question. Yeah, so we have the primary healthcare administration, whatever, that regulate all primary healthcare in Nigeria. So once you get your permission, you have access to like all the pills that you don't need any other access. You just need from that particular administration. Yeah.
Yeah, I think that, I think that's one of the areas that's just super important to be able to understand that this is one of those key things that we talked about in the last workshop, a contextual factor that you match your strategies to. So they don't really need a strategy that's going to convince each individual community health center. They need a strategy that focuses on a centralized decision maker. And so that's going to be a lot different than other places where you go in a context and there's not that centralized approach. So that was super helpful. And God, it's awesome when you get into places where there's somebody that can say yes for 60 minutes.
Yeah, so I mean, that's also a thing that the person says, no, there's nothing you can do.
Yes, exactly right.
Why do you think the retention rate went up with the more time that passed?
Good question. One of the things that we saw was like the fluctuation in blood pressure was depending on weather. In April, December, people get impaired. They get more compared to other like months in the year. So one of the possible explanation was just the season. But that's one. So the other one that ensure that, so now the PHC, so I think one of the reasons was when we started implementation, and the medium, the CHCs were trained again as well. So we think we also contribute to them providing like care and everything patient care. And we do a lot of community engagement. Even try period that we have to contribute to why people are in so community engagement, the training, consistent training. Because what happens was we do monthly reports, so we do quarterly meetings. We submit monthly report, but we need quarterly to look at, okay, what the treatment is like, the control is like. What do we do differently to ensure that people are retaining them? So based on that discussion, we put in strategies and report that if we need to do more community engagement, we do that. So like different things are happening. So I think multiple strategies adopted to keep patient.
Did you use incentives at all? Just thinking about your kind of amazing patient uptake, 98.5%. Did people receive any kind of material incentives for participating? And how does that sort of fit into like being, do you do incentivizing participation kind of muddy the waters of implementation, or is it like a welcome accelerator of implementation,
Yeah, good question. So the main incentive that we used was the free medication. For the first 18 months, they got free medication and they didn't have to pay for everything. So that was really, really good. So by the time we switched to drug from the revolving fund, it was easy. Because they already know, okay, this is a care. And when we engage them for that drug revolving fund, we kind of talk to them, this is what we want to do. We're not paying extra money, we're paying just the cost price of the medication. And actually help them as well. With that. So I think the free medication really prepare them for that. They were not giving money, but they did pay for medication. And they know that when they get medication from the place, it's pretty much cheaper than going outside the family. So it was really easy to convince them. Yeah.
Yeah, I think we're doing well for time. So if folks want to take a 10-minute break, we'll kick back up at 10:25. Right back. All right, folks, I think we're about ready to get rolling again. Saw Toby trying to get this stuff off of there. Okay. Great. Well, welcome back. Thank you, everyone, for coming back. Knowing that Toby was finished, I thought everyone would just take off, moving. Okay, so one of the things that Toby walked through and did a very deep dive on was REAIM and how you can apply REAIM in planning and evaluation of a study. And so what I wanted to do was just kind of bring us back a little bit to the idea of REAIM and Proctor's implementation outcomes framework and give you a little bit of definition. I know this is so exciting, some definitions. And I'm not going to read through each of the definitions that you see up here, but one of the things that I wanted to point out was within the Proctor implementation outcome framework, one of the key differences from REAIM is this set of three outcomes: acceptability, appropriateness, and feasibility. And you can see what the definitions of each of those are. It's important to note that these are perceptions, right? It's talked about as perceptions. And we could get into some discussion at some point, maybe even at the end of this, if folks have questions about how we might measure things like actual feasibility. And so we'll continue on. So just know I wanted to give you those things here. And then the things that are very consistent between the two frameworks are the AIM components, right? So adoption, implementation, and maintenance. And whether the labels are exactly the same, the definitions are very, very similar, if not identical. And so you saw these definitions from Toby. You can see up on the top there how implementation outcome framework defines a specific outcome and how REAIM defines that same outcome. And again, I didn't want to just start reading definitions to you. So hopefully you guys can look up there, take that in, and we can move forward. Then the areas where there's a little bit of difference is this idea of reach. So reach is pretty well defined and has been used a lot in REAIM for, since REAIM was first published in 1999. So it's been around and out there. But for the implementation outcomes framework, it's oftentimes included in the idea of penetration. And penetration is a construct that, again, is unique to implementation outcome framework and not included in REAIM. But if you thought about it from a REAIM perspective, it really is kind of a combination of adoption and reach. So how well the intervention penetrates across a system and then into the audience that you're expecting or hoping to have an impact with. And then finally, costs. There's a lot of different ways to categorize costs. We are definitely not going to give cost its full weight here today. In fact, I think at some point we should probably have a workshop just on implementation costing and what it means to do those different things. But you can see here again, within the two frameworks, cost is operationalized fairly similarly. Okay, so with all of that, I feel like you guys are now prepared for this question. Okay, and I've just got the REAIM things up there. So which outcome is the most important one? And online, I want you to type in the chat. Okay, Hannah?
I would say maintenance, because what are you doing it for?
Okay, what maintenance? How many people are going to jump on board with Hannah and say maintenance? Oh, we've got like 3 maintainers in the room. Okay.
I would say reach because if you can't reach the population that you want, it doesn't matter if the program can be maintained because it's not getting the audience that you're.
Okay, so hold on, James, before you jump in there. So we've got now a vote for, it's Kathy online. We only got, come on online people, let's get some votes in here. We only got 1 agreement with maintenance, but we now have a vote in the room or a raising of reach as the most important, because if you can't get the people in the door, there's nothing to maintain. Okay, so that was the point. Oh, Vanessa's throwing him. Okay, James, I'm going to go to you, and then I'm going to tell you what Vanessa said.
Oh, I was gonna say, like, if you're at the point to maintain something, then everything else has already been reached, adopted, and implemented. So you can't get to maintenance until you've done those things. So
Okay.
that's why I said maintenance.
Okay, so James is saying you can't get to maintenance without all of the other things first, which would make me think that if it was a causal chain, that something earlier in the chain is probably the most important, which would then say Kayla's idea of reach might be there, right? And then we have, okay, Vanessa says adoption. let's see who wants to speak for adoption first before I'm gonna let you go.
Yeah, I was thinking adoption too, because you can have the reach and effectiveness, but if no one takes up your program, you can't do implementation or maintenance. So that's kind of like a checkpoint where the progress would stop if no one adopts your program.
Right. Okay. So adoption even before reach, because you have to have the existence of the intervention before you can reach anyone, right? It has to be, okay, I'm going to go here and then at the back.
No, I was like, I can't.
You know, I'm not surprised. Yeah.
In the gas station to buy a drink soda, but I'll make a plug for effectiveness just for fun.
Okay.
Something that doesn't work.
Okay. So we've got now we've had effectiveness range. Why would we maintain something that wasn't effective? Why would we even have it adopted? Why would we do anything with something that wasn't effective? And so Vanessa, first of all, I want to say she doubled down on your adoption description there. So excellent. We have some good engagement going on here.
More of a question for implementation focused research. Are we sort of starting with the premise that this is an effective intervention, or not?
Yeah, so this is a great question. In dissemination and implementation science, are we starting with the understanding that the intervention is an evidence-based intervention that's why we're doing all the things we're doing around it? What do people think?
We need to do a hybrid design.
Okay.
Be
So
testing.
okay. Hybrid designs. So that would say that we still do need to focus on effectiveness. So if I was just given a quick answer, I would say that whenever we do our training workshops around writing grants for dissemination implementation science, the first thing we tell people is if you can't defend that your evidence-based intervention is in fact effective, you're not really going to be very well reviewed if you're kind of focusing on dissemination implementation science. Now, if I was being more complex about it, I would think more around improvement science and public health in general, where we're thinking about a lot of these things for designing for dissemination right from the get-go. And so effectiveness might not be a guarantee at that point. Okay, so are we agreed? Okay, I think that this is, so someone in the chat, I thought I saw it where, yeah, Brandy did a great job facilitating one of our community engagement activities this week. And she says, it depends on the goals of your study. And so, at the end of the day, that's really, it is, what's the gap? What's the priority? What's the thing that's going to help you to, I always think about public health impact as my ultimate goal, which, I still fall back to the old reach by effectiveness, your public health impact. So I think we want to be able to get good impact broadly. And you can't do that unless you're focusing across these areas, right? Like it's really hard to say. And I think Kayla gave a nice example, and then I think others did too, of as soon as you zero out any of these things, the rest of them become unimportant, right? And so it really is typically driven by the priority and your partnership. Okay, great. Us along. So I worked with a postdoc and a couple of doctoral students, and we, Catherine Riley led this paper. And what we wanted to do is a little bit of crosswalk. I know this is super small. I'm sorry, it was a table in the paper, and I just felt like I didn't have the time to make it into a nice slide. But you can see it on the crosswalk here. For folks online, you can probably see it very clearly. What we have on the y-axis there is the implementation outcome framework outcomes. And then what we have on the x-axis is the re-aim outcomes. And what we did is we tried to go through and say, well, what are things that are consistent between frameworks? And so you can see the C's on there are things that were consistent. We also wanted to know which things were at an individual level versus an organizational level. And probably the most important thing that we wanted to try and focus on at this time, and I think we published this in like 2020 or somewhere around there, and was that, we kind of had a little bit of just an itch to scratch around acceptability, appropriateness, and feasibility as being predictors of outcomes rather than, or determinants, you might want to use that term, rather than outcomes themselves. And the way that we thought about it was that an outcome should be something that if you tell someone about it, they know about the impact, the number of people, the magnitude of effect, the number of organizations and staff, the quality of implementation, the degree of maintenance over years, months. So things that you can say, if I told someone about that, they could really get on the idea of impact, versus things like acceptability and appropriateness, which are typically scored on a Likert type scale, and probably in and of themselves aren't very compelling if you're talking to partners or organizational decision makers about impact. And so that was really where we started from. I would say I've softened my view a little bit on that over the years, but we still do in our work focus on these things more as antecedents to the outcomes rather than as outcomes themselves. And so we focused on an expanded REAIM framework. And again, Toby did such a nice job walking through the definitions. I just wanted to show you a little bit of what things could be different if we tried to integrate both of these ideas together from the two different frameworks. And so here you can see from REACH, the additions here are really the second point. And someone asked earlier, I can't remember who asked about cost, like incentives, right? You said incentives, like is incentives a thing about, well, absolutely. And so one of the things that we now have embedded within this type of expansion is, what are the cost of the strategies themselves to improve reach? A lot of times we're focused very tightly on the cost benefit of the evidence-based intervention, and we kind of don't think about the costs of the things that are leading to the implementation outcomes. So for that one, was focused on reach, using incentives to improve reach. Well, we need to understand the cost of those incentives and the relative return on that investment in terms of number of people that end up enrolling and benefiting and that kind of thing. So that's one addition. And then the second addition is this idea of acceptability, feasibility, and appropriateness. And so I pulled out an old study that we had done where we had most of the information. We have, the number of the percent and representativeness. That's our standard REAIM evaluation parts. And then we assessed appropriateness, acceptability, and feasibility qualitatively through participant interviews about the program themselves and how acceptable it was for them. And then we also tracked the cost. In this case, it was minimal because it was a point of care referral. So it was kind of embedded within a primary care physician role. So then if we wanted to look at this, the adoption, again, you can see point 1 in this definition is it's the REAIM definition. And then we add in the idea of costs. And in this case, one of the areas that we think a lot about in adoption is the startup costs, because the startup costs are often quite different from the ongoing implementation costs. Right. So what does it cost to get things up and running? I'll give an example in a little bit, and we can talk about some startup costs there. And then what are the costs of the strategies we're using to try and get staff, organization, system adoption of an intervention? And then what are the antecedents from acceptability, feasibility, and appropriateness? But in this case, not from the perception of the potential participant, from the perception of the people that are going to deliver and the administrators that make the decisions about what can be delivered within a system, right? So their perceptions of these things is fairly important. And here again, we have something that I'll talk a little bit more about in a larger example I'm going to give in a while was the Building Healthy Families program, where we used a fund and contract strategy to try and engage communities that had a priority for childhood obesity treatment. And you can see the outcomes here. 7 organizations providing services to 18 counties responded to that strategy, which is a 19% adoption rate. The representativeness, you can see they represented counties reflecting the rural population in Nebraska, so it was representative. And then you get to the things like the startup costs. So here, I actually have it right here on this slide. In this particular case, costed out, whether this is the real startup costs together, but the the group that delivers Building Healthy Families, including myself, who came up with ideas about what does it cost for all of the facilitation support as well as the materials. The startup cost for a community is about $12,000. So that's an important thing. Community, it's a real number that a community needs to consider through in the adoption decision-making process. And then we're still working on costing out things like our fund and contract strategy. And then you can see here the high baseline perceptions of the intervention itself from the perspective the community implementation teams was high, with scores of greater than 4.5 out of 5 on a 5-point scale. Okay, implementation. This is one that really there was a lot of additions to when we walked through it. It included adaptation. I don't know if people noticed that adaptation wasn't on either of the original frameworks. So that one we kind of put in there as well, because both talk about adaptation a lot, but didn't have it necessarily in any particular dimension. So tracking adaptations, and then again, adding in this cost, acceptability, feasibility, and appropriateness. And this one, I'm not going to go through the details. The one where I think that there's still so much work to do. So if you are people that are interested in and beginning to do dissemination implementation science, I think that maintenance at the programmatic level, there is so much work to be done. And so even though we kind of walked by maintenance as maybe the most important, because we know there's not necessarily just one most important, but it is probably the least studied. I don't know. Toby, James, JD, do you think maintenance is the least studied implementation outcome? I'm getting some nods. Cost, maybe cost. Okay. All right, so this is an area here. Again, you can see we've got the re-aim institutionalization definition, and then costs, and then finally, again, the acceptability, appropriateness, and feasibility. And the thing I wanted to point out here was that one of the other things about acceptability, feasibility, and appropriateness is that it's temporally loaded, right? Like I have these perceptions in pre-implementation about what I'm going to implement. Then I have perceptions while I'm implementing, which can be very different from my pre-implementation. And then I have perceptions post-implementation that can be very different from during implementation and could be very important for maintenance, right? And so even though it's these same three things we're talking about, it's oftentimes from different constituencies, perspectives, and at different temporal time points over time. James.
Yeah, around maintenance, in the field and in the literature, I think the challenge for how to measure and how to identify maintenance is present. Like when does maintenance actually start? Is it, sometimes we think about it, it's a year after you have adopted and improved it. Is it after you remove resources, and is that a feasible thing to do? So I think like when I've done systematic reviews around trying to understand if the sustainability or maintenance has been measured, under like trying to find a common definition of what does it mean to actually maintain something, and like the time period beyond. Sometimes studies will continue to collect data, or they'll go back for one data point in 12 months.
Yeah.
So kind of getting more clear around what that is might make it more likely to be studied.
Yeah.
Maybe it's studied, but we don't really know how to capture it very well, because we can see like adoption, we can see fidelity, but
Yeah. Yeah, James was making a point about, one of the challenges with maintenance is just even like what is maintenance? And a lot of times I'll use terms like sustained implementation. So what does that mean? Well, sustained implementation beyond the life of the grant. Okay, well, is that like a month after? Is it 6 months after? Is it 12 months? And if it's after the grant and your study, how do you know what it is? And so there's a lot of things that we do need to be considering as we think about maintenance. And maybe I will draw the attention to the one graph that's at the bottom here. This was I think maybe my first study that I used re-aim as a planning and evaluation framework for. And I don't know if you can see way at the back, but the first year is 2002. So this is an old study, but our study was actually in 2002 and 2003. And then all we did is went back to our community partners to see who in the organization had adopted the program that we had created together. And so that you can see the extensions to each of those bars, and then who continued. And one of the things that we found was that, for 3 years after that program was developed and tested, it continued to be delivered in rural Kansas. And so is that maintenance? I'm getting a lot of nods in the room. I think it's maintenance too, but we didn't really plan for that. Oh yeah, we just wanted to track that. And we thought it'd be really nice to be able to show where are we at 5 years after and what's the reach of the program. And we have all of those types of things, but it wasn't part of a study and trying to get down to these definitions. And so I think maybe James pointed out a really nice thing here too, that we could be focusing on, what is institutionalization as part of routine practices. Another indicator I've used before, did they integrate it into job descriptions? Right, like it's a pretty good indicator of maintenance. And for those who are online, we're getting nods to a lot of these indicators, but I think it's really even underscoring James' point that we have all of these things, but we don't really have a tight description of what that maintenance is. Thanks, James. Yeah.
There was a question online, but. Oh, yeah. Okay. So can you talk more about testing and evaluating strategies like training, text messages, audit, and feedback to improve the uptake of interventions, particularly at the same time as looking at the effectiveness of the intervention?
Oh man, was that Mike that asked that?
Yeah.
Oh, I think he must have been looking at the slides, because that's what we're going to do next. So we will walk through some of this, and hopefully please ask questions too if I don't get to everything that you had in there. But I think that, yeah, what I wanted to shift to here was giving you guys a bit of an example of how do you make decisions about what is the dissemination and implementation outcome that you're going to focus on. And then the other thing to think about is, like, if you pick one, is that the only one you measure? Is that the only one that you focus? Like, how do we do this in a real full project? I think Toby gave a nice project. I'm going to try and integrate implementation strategies into this as well. So that's where we're trying to build a little bit on what Toby did in the first slides. So I'm going to give you, oh, sorry, Heather.
Just wanted to ask, maintenance, is it more of like a passive thing? Like, if you said too, like, it doesn't have to be part of like the research study, but like, is there ever, if you notice during like the maintenance period that it's not going well, do you intervene at that point and kind of like restart your process? Or how do you know how long to do maintenance for? Like, I guess, yeah, just better understand.
Yeah, Heather had a really good question about whether maintenance is a passive thing that, you kind of set up, you watch it. If something goes wrong, you try and intervene and see if you can keep it going. And I would say that it's like any other outcome. If it's not the focus of your intervention manipulation, it probably is relatively passive, right? But if it is the focus of your manipulation and you say, so we did early on, and we didn't do it in an experimental design, but we developed a sustainability action plan to walk through with our community partners for once they'd gotten a physical activity program up and running in their community. And so there was a number of steps towards how you would work to getting the program integrated into job descriptions, how you would look at the budget. If is it internal budget only needed, or is there external budget too? Doing a matrix of connections and how we might go about that. So very planful, walking through with the ultimate goal that once the research support is done, this stuff would be able to be sustained. So in that case, it's not passive at all. It really is very active, working towards maintenance itself. But I would say that it ran it, and again, this one we did 15, 20 years ago. So, but it ran into the issue that James is saying, that then we didn't track, like we did it. And we have, I think the end point of our paper was your perceptions of the likelihood of sustainability. I think that's where we stopped. JD, did you want to weigh in on that one?
Beneficial about it's really dependent on your study design, research questions. So there are definitely designs that you do certain strategies to help implement, and then as you move to sustainment, you might introduce different sustainment strategies.
Yeah.
But if you had planned to introduce, if you see that it's not going well,
yeah,
you might be stuck. Yeah.
Yeah, and remind me when we get to the audit feedback around maintenance on this one to come back to this topic, because it'll show you one where it's really built to be in the community where the things are going on to allow them to continue to focus on outcomes that are important to them for sustainability. Okay, so this is from, I don't know that I said it out loud. This is from our Mountain West Prevention Research Center. This is our core research project that I'm going to talk you guys through a little bit here. And we used the IPARIS framework and REAIM in our framing of this study. And we also developed it in collaboration with a lot of different types of partners, but I'll kind of walk through this. So the challenge that we were trying to deal with is that there is increasing inequities in obesity when you start thinking about high income urban populations, low income rural populations. Over the last 5 years, obesity rates increased, low income rural areas decreased, high income urban areas. So when you get that kind of thing going, we're starting to see worsening of differences rather than improvements. So that's the first thing that we wanted to try and address. And the second thing is that within, particularly in rural communities, there tends to be fewer contained resources to deliver an interdisciplinary family healthy weight program. So, you don't typically have a big clinical partner. You may have a clinic, but the clinic might just have a couple of primary care providers, maybe a couple of pediatricians, a nurse, but they don't have everything that is typically suggested for evidence-based family healthy weight programs. And then even within that, and maybe because of that, it's really hard for community groups to have some way to get together to identify families that could benefit, engage them in the process of enrollment, enroll them, and then have them participate. So these were the things that we were really trying, that's really the challenge, maybe more appropriately the context. So on the other side of things, the promise of evidence-based family healthy weight programs like Building Healthy Families, and Building Healthy Families in particular was developed using a participatory approach with and for rural communities and small towns. Okay, so it's a family healthy weight program that is based on, adapted from the best available evidence for childhood obesity treatment, and has demonstrated effectiveness when delivered in rural audiences. Okay, so that's our evidence-based intervention. So to that point earlier, this one, yes, this is an effective intervention. We'll still measure effectiveness, but we start from that idea. So our community partners here, right now within our Mountain West Prevention Research Center, we've developed a lot of community partnerships in our Family Healthy Weight Collaborative. You can see here it's across 6 states. I won't list them all, but hopefully you guys know your geography. You can look at the shapes of those states and you know where we are. And then we have a number of different types of partners. And they're all partners that could contribute to or have a prioritization around helping families, children to increase physical activity, healthy eating, and in some cases, weight management, in other cases, just primary prevention and health promotion. So you can see on here, the state health departments, local health departments, those two things are different. Cooperative extension, a big player in rural areas across the United States. Parks and recreation, also a big player in recreation activities for kids and families. Healthcare centers, because you'll see one of the issues that we have really could benefit from the collaboration with community health centers, and then generalized kind of community-based organizations that have interest in childhood obesity. Okay, so together with that partnership, we went through a number of virtual meetings to come up with a shared vision and mission, and you can see those up on the screen here. I'm not going to read through it in detail. And so then we started to understand, and we'd learned this before the collaborative as well, but that there are a lot of assets out in these communities. Just because they don't have the traditional resources that have been traditionally applied to family healthy weight programs or childhood obesity, they still have a range of assets that can be applied to childhood obesity. And so Dr. Hill here in our Division of Population Health Sciences, and Kate Heelan from University of Nebraska Kearney. They led the Childhood Obesity Research Demonstration Project for Nebraska. And what its goal was to take Building Healthy Families and create an online training and program package that had everything necessary for a community to deliver the program. Had all the participant-facing materials, had all the training, had a data portal to be able to track outcomes, had video content, had fidelity assessments that they could do for a quality improvement of their own. So everything they needed within one press here to start to develop your community capacity. And they also added, they compared that alone or that with an action learning collaborative process. Okay, and I'll get through a couple of these things in a little more detail and a little less detail here. So what did they find over 7 communities that participated? And so I'm presenting the information on the group that had everything. Okay, so they had high implementation fidelity. So remember, we were doing our ratings. What would you guys give this on a 1 to 5 point scale? 84 to 91% implementation. And this is direct observation. So this is people going in the room and watching. This is not self-reported. So that's pretty good. That's pretty good, right? A clinically meaningful weight loss for the participants, about a 5.15 reduction in BMI Z-score change, which is very comparable to what is achieved in community settings in urban areas and in many of our research studies. Okay, so really good. High participant attendance, and this is at some of the, I'm not sure exactly what our denominator is on this, but still, if 94% attendance is pretty outstanding. And so then we also still have a challenge, though. Across these 7 communities, they were able to recruit about 4 families on average per cohort. And so one of the things that we're just going to imply as we go through here is that there's a lot of relationships within dissemination implementation outcomes too. And one of the areas that I'd love to see a little more research in is the interplay between reach and sustainability or maintenance. Right? If a community is only reaching 4 or 5 families in a cohort, you know, what's the likelihood that they're going to want to continue to do that program over time? And so what we found was, so that I'm going to give you that stuff. Now I have another poll question. So I've given you all of our context and I've kind of led you right down to the water like a horse. Let's see if people will drink. So far, what do you think the primary outcome of the Mountain West Prevention Research Center core research project should be? Anybody? See if the chat, is anyone really fast on their fingers? And what do you think?
So you're saying all that stuff that you shared, just like the baseline before this?
This is all kind of the context before we've started the. Yeah, Heather.
Reach maybe adoption, because it seems like it's effective. We know it's gonna go in. It seems like this program has already evidence base behind it, so maintenance could be easier, but it's not getting to a lot of people. So that would be a challenge, I think, in having people adopt it, having people implement it, if it's not reaching a lot.
Okay, so we've got 2 things. Heather nominated 2 things. One would be reach, one would be adoption. Raise your hand if you think reach would be the primary outcome. Okay, raise your hand if adoption would be the primary outcome. Okay, I would love to do a study on adoption. And in fact, we've written a couple of things up and we'll see if we have time. I have some things to talk through about adoption that would be interesting, but reach is the answer. So our core research project goal is to develop sustainable strategies to improve program reach. And we decided still to even focus on retention, even because we feel like, why do you think we'd say retention, even though we have really high attendance? Why do you think? Anybody have an idea? Maybe I'll move us along and not pull. Go ahead, Heather.
I was gonna say, you want it to continue. If people are doing the program once, that's not effective to happen.
Okay, so you want people to continue. One of the core reason is that one of the things that we know is that when we increase reach, we may also increase the diversity of motivation for a program. And so you get a higher number of people in, but that also means you've now, those 4 families that have come, they're very motivated. They're highly motivated families. We probably didn't need to do very much for retention for them besides put on a good program, right? And so as we increase the reach, we may increase that motivational diversity within the group. So we want to make sure that we have things to keep people engaged in addition to delivering a high quality program. Okay, so here is the project. I'm going to walk through it relatively quickly, but building healthy families, program orientation and enrollment. So enrollment is our primary outcome. Okay, the proportion, the number and proportion and representativeness of families that enroll in the program, that's our primary outcome. And so the way that we proposed to do this was that we would have communities respond to a fund and contract adoption strategy, and they would have a partnership between a community organization that would deliver building healthy families and a community health center that would use their electronic health record to identify families that would be eligible for building healthy families. Okay. And then we have an automated approach that my MPI on this, Guilherme Delfil, has, that he can interface with electronic health records with very low burden to the community health center and be able to do direct text message outreach to families that we identify as available. Okay, so that's our identification row. And then here's where we start to get to our randomization. And so we have everybody that gets anything here can have a self-enrollment opportunity. That this is our original slide. We say it's embedded within the text messaging. When we actually get to the mechanics of it, they can't actually just press the text message thing and be enrolled. There's a few other things that they'll need to do. And so the randomization is that we'll randomly assign families right from the get-go. So if anyone's wondering about consent on this type of thing, the way that we do this type of project is we send a mailer with information on the study, the program, that people can participate in the program even if they don't want to be in the study, but that if they want to opt out from getting text message invitations, they can opt out. And so then we wait for folks to respond to that. And then those that don't respond to opting out, we then start this process where they're randomly assigned to either getting a single text message with or without active follow-up from the community implementation team, or they get repeated opportunities for enrollment. So repeated text messages with or without community implementation team follow-up. And the repeated opportunities, we'd initially proposed, I don't know if Megan McKay was on this. Yeah, Megan's still on here too, but we initially proposed that we would do that 6 months, so 1 a month over 6 months. And then when we went and met with a few different community health centers, they're like, well, you're going to enroll someone 6 months and they're not going to be in a program till, like, they're going to forget about it. They're going to lose motivation. They're not going to want to be. And so I wish we would have even thought about that early on, but we didn't. And so now what we're doing is 3 months. So initiate 3 months, do it once a month over 3 months with or without. And then, as I said, there's enrollment, and it's a smart design. So once folks are enrolled, we then randomly assign them to our different recruitment strategy or our retention strategies. One, which is a pretty standardized approach. We'd send people reminders before every session. Just, hey, don't forget that we're going. And that's typically what our communities have done. Or they would get that weekly reminder with motivational content that aligned with the program themes of a given week and time. And then with that, we'd look at program attendance over 12 months for building healthy families. Okay. How am I doing? Oh, I think I'm still doing pretty good on time. All right, so now, Mike, I think I've given you all kind of the setup and stuff. Now we're going to get a little bit more into some strategy stuff. And one of the things that in the next session, you guys are going to go through, the next workshop will all be on strategies. So I'm going to go a little bit light here, but one of the things that we wanted to really start to make people a little bit aware about is that within the field of dissemination implementation science, I think one of the things that I do very planfully is I always say dissemination and implementation science. a lot of people just say implementation science. And what happens then is you kind of lose part of our field and what we're trying to focus on. The other thing that we run into is also the labeling of strategies. People talk about implementation strategies for things that have a wide variety of different outcomes that they're trying to achieve. And so what we're really trying to push a little bit here is to label your strategy, not just by the ERIC label itself. I would still use those, but I would also say this is a reach strategy. This is an adoption strategy. This is an implementation dose strategy. This is an implementation adherence to protocol strategy. This is a maintenance strategy, so that you're very clear on what it is that the strategy is trying to achieve. And that's why we brought it in here, because really all of our strategies come from kind of the in-betweens of what's the priority outcome and the context that we're in. And we design the strategy to fit the context and to change an outcome, right? So I'll go through. And so here's a re-aim strategy that we would be a strategy for reach. We're defining that as a strategy focused on individual level dissemination of an evidence-based intervention intended to improve reach. So here is a little bit more detail. This is one of Guilherme's figures that we have that demonstrates a little bit more of the mechanics of the text message outreach. Our name of our approach is direct text message outreach, so very descriptive of what we're doing. And then we specify it as who's delivering it, technology in this case. And we have much more detail on that in the specification documents. And then we have the action, direct messaging to families with or without active follow-up. And then what we're trying to do is we're trying to improve family awareness of the programs and motivation to engage in the intervention, our mechanisms of action to improve reach, primary outcome. Okay, so that's one place here. And so, if you want, you can try Healthy Fam Sam. That is the fun name that our creative team, Alana, pulled out for us. It's very prototype still, but it's, yeah, go ahead and you can look at Healthy Fam Sam, but it walks people through the process to get them enrolled in the program. I'll pause there for just a moment in case anybody online is trying to capture that one. Oh my gosh. Megan, did you send that chat to everybody? They are not a terrible partner, just so they know. Okay, okay, where am I at here? Moving along. Yeah, go ahead.
Oh, sorry, that's not what you're saying. That's where you're getting into like the mechanism of how that's
Yeah, and again, like I said, James and JD will get into strategies and we'll go through very explicitly the specification processes. And so I've given you here what I think is a decent specification, but it's specification light. So that's where I'm going with. But so our second strategy, and I talked about this one a little bit earlier, the strategy, an adoption strategy, a strategy focused on improving staff, organizational setting level adoption of an evidence-based intervention. This one is a fund and contract intervention or strategy that's intended to improve community uptake of building healthy families. Specifications, we sent an RFA that was distributed by our community advisory board. This was when we did it in Kansas, or not Kansas, God, that was a long time ago that I worked in Kansas, but in Nebraska. We've also done that here as part of our PRC. It hasn't been as successful as it was previously, but we can talk a little bit more about it. But we distribute that broadly. Then the communities respond to the call for applications, and we review that with the community advisory board and the investigators and the program development team. Then we create an MOU. That's the agreement for them to deliver the program. That's the action. So very quickly kind of walking through that. And then for this one, we're hoping that it will improve compatibility with community priorities by sending this out. So we get that community priority matching, which is the mechanism which would result in improved adoption and dissemination outcome. Okay, so there's another very quick description. So then our implementation strategy, this one is focused primarily on adherence to protocol for building healthy families. You can see this definition is a strategy that focused on improving implementation of the evidence-based intervention. This one's online training with knowledge checks. And so the things I've put up here are our training materials that we have on the Building Healthy Family online resources. In addition to the training materials, they have to do little quizzes to make sure that they have the understanding of the content that they're going to deliver. And more content is actually locked until they can pass those knowledge checks. And so it's got video, it's got everything needed to train up the team to deliver the intervention. And again, you can see the who, the action, the mechanism, and the outcome. And again, I won't read through that in detail. Now, but let's get to the maintenance one. So this is a strategic approach to try and maintain a program beyond the life of just a specific grant, even if it's a dissemination implementation grant. And so for this one, within the data portal, within the online resources, we built a data portal that allows reporting for the community implementation team internally or externally. So they can share, de-identified reports that provide observability of the effectiveness of their intervention that they can share with other groups that are important to their sustainment. So it could be their funding groups, it could be, parents, it could be other people within their organization that are questioning the value or, trying to do priorities within their work. And again, you can kind of see through the specification on that. So I'm going to just give a quick pause there and see if there's any questions at this point. Yes.
So your goal is to increase reach if you've got all these diverse sites. Like, I'm not sure where your New Mexico site was, but it looks like it's around Gallup. So let's say it went there, which is a tribal health system, and you're finding that you're having trouble, like different barriers to different places. And
yeah,
then how is it, can you adapt your strategies in REAM, or does that sort of hurt fidelity and kind of come at the cost of
the study kind of, yeah. Yes. So the question was, it's likely that in our communities, there's going to be differences in what's successful in recruitment. And so I would say from our study perspective, we're over the course of the study, we're not going to do any adaptation to the fact that we're going to compare single versus multiple text messages with and without follow-up. It's unlikely we're going to change that because we programmed it, we've got it all together, and that will go. But within the online training, online resources and program package, we also have a full recruitment module that walks people through step by step to identify within their community what are ways that you get messages out, who are the folks you should talk to, how would you do it. And so even though we're doing this population health management overarching study, we encourage and actually facilitate every community to do a kind of a whatever works best for your community, let's add that onto it. So it's almost more like an additive adaptation rather than an adaptation to the core. So we'd say we have the core text messaging approach, and then we have community-specific additional opportunities to recruit folks. And that we anticipate will be quite different from community to community. And so then we'll just see, is what we do additive? Right. So it still ends up keeping a nice tight study for us to be able to do. Yeah.
General question, but is REAM ever applied retroactively or retrospectively maybe to if you have something that's been implemented, maybe it's been implemented in the community for a long period of time, something might be state funded, for example. I think what I'm struggling to figure out is can you only apply this in kind of this
prospective?
Yeah, examples that we've been getting, because I can see how you can have a lot of ownership over, these definitions and all of that stuff, but what's how do you think about it in a different context?
Yeah, so the question was, can you use REAIM retrospectively as well as prospectively? And I'd say absolutely you can. It's like anything, if you're If you're using a model prospectively is easier because you identify how you're going to gather the information. But REAIM has a pretty good utility that, you know, most things that are going on in a community or a clinical setting, you can typically get reach on. You can typically get representation. The variables that you can compare representation on are going to be different from place to place. And so might not be ideal there, but yeah, I think there's lots of folks that have done retrospective adoption types of studies of what's the spread been. I think the implementation fidelity stuff is a little bit trickier unless, you know, they had something built in, but yeah, you definitely can. And I'm trying to think of, I don't know that we've ever used it retrospectively, but I know that you can. Yeah. Okay. So any questions on this? Any other ones? Let's see, nothing in the chat. Okay, I'm gonna move us along, and a lot of times we get asked about like logic modeling and how we're putting that together. And I'm gonna put a plug in, get your cameras ready. There will be another QR code probably in like 20 minutes, but it's for a study that we're doing on how people have been applying implementation research logic models. So just be ready for that. So what I wanted to do here was now walk you through the project in kind of our planning approach, but also a way for us to be able to describe what we're doing. And so one of the things that we said early on is that even though our study is all about reach, there's a lot of things that we did in our previous studies to get communities ready to deliver the program, to adopt the program, to implement it with quality, and then hopefully sustain it. So there's other things that we need to do, but let's just start with reach. And we always start with kind of the end point here. And so for this one, you know, reach here, what we're looking at is, as I've described before, number, proportion, representativeness of people from those electronic health records that we identify as eligible families that end up enrolling in building healthy families. Okay. And so our context here is that we found over a number of different community implementations that there's in any given community, they have a really hard time finding a sustainable process to identify and enroll eligible participants. And as you can expect, you know, like word of mouth, we've found in one of our early studies was a very effective way to get information out on physical activity programming in rural areas. It's not quite the same for childhood obesity programs because there's a little bit different perspective on that, and you run into a little bit more stigma and those types of things. So it doesn't quite work. The word of mouth doesn't work quite as well. Not that it doesn't work at all. And so we designed, so this is how we think about it. We designed a population health management automated text message outreach approach. And we propose that the mechanisms through which it would work is it increases awareness of the building healthy families characteristics. So that could be things like acceptability, feasibility, and appropriateness from the family perspective, right? Because many families never hear about the local program, right? They never hear about it. So one of the mechanisms is, can we get families to hear about it? The second thing is that it improves integration between the health system in the local community and the community program team, which would increase reach as well, we think. And then it increases the ease of enrollment. Within IPARIS, we would talk about that as complexity. We reduce the complexity of the process of enrollment. And so that's our mechanisms. Okay, so pretty straightforward, right? Okay, so we then also want to know, well, how effective is it? And this is one of the areas that we are studying cost. And costly would it be to do community implementation team follow-up on every text message invitation that goes out? And so we think that this actually works through a couple of different types of mechanisms. One is that it would increase the acceptability because I get contacted by a known community organization. And so I feel like that, wow, oh, this program is delivered by you guys. That makes it more acceptable to me. We think that would increase the reach. And then we have repeated opportunities for enrollment. And again, mechanisms that we would think that would work through is increased family motivation to enroll. Maybe multiple prompts helps us to think, oh, yeah, maybe I should do that, or increase my motivation to engage. Okay, so that's all this purple stuff. This is our study, right? We have randomization. You saw how we do the randomization and that kind of stuff. But this is our implementation research logic model for REACH. Okay, so we start here. Did you have a question? Oh, okay. And so then the next thing that we want to think about is adoption. And of course, adoption does temporarily typically precede REACH, right? Usually you have that in place. So I just wanted to throw that out there. But for adoption, this is where a lot of the communities that we worked with, even before we developed the online program package and training materials, was that they just had a really hard time finding materials. Like they were interested in delivering a program, but it was really hard to get all the program materials together. And so just for this contextual factor, we developed the online, well, as part of that, we developed the online training resource and program package that had all the materials in one place that a community would need to deliver the program. And because of that, we felt like the mechanisms would be that it would make the program be perceived as more feasible, more acceptable, and more appropriate, and that we would increase community access to these materials. And by doing so, we'd increase the likelihood of adoption. Okay, the second thing that we have here is we also put together a kit of like equipment, activities, things that the folks could use within their programs. And so that was another thing, just getting all the activity materials together in one place. Again, you see that little arrow pops in there, working through the same mechanisms as our initial strategy, and moving its way to increasing adoption. Okay, so now I'm going to move on to implementation. And like, hopefully this is, maybe I'm going to just stop here. Is this helpful? Like I'm hoping that it gives you a sense that our study is just about REACH. But even though it's just about REACH, we have a lot of strategies going on here. And these are strategies that we can descriptively evaluate as we're doing these projects and also contribute to the generalizable knowledge around dissemination and implementation. It's not as rigorous of information, but it sure is nice opportunities for us to build, as Heather said, well, adoption would be nice to do. Well, that could be one of the studies that we're gathering preliminary information about adoption issues that we might be able to overcome in a future study. So I just wanted to throw that out there too. And okay, so let's go on to implementation. So for implementation in this one, our primary contextual factor is that one I talked about earlier, is that there's just a variety of people and resources that changes from rural community and small town to rural community and small town, right? Some might have a Parks and Rec, some might not. Some might have cooperative extension, some might not. Some might have primary care provider, some might not. Some might have a dietitian that's at the primary care provider. Some might have a dietitian that's at the grocery store. Some might. So there's a lot of different ways. And in fact, I think when we, I don't have anything on this, but with the Cord 3.0 project, I think we ended up with something like across the 7 communities, 40 different backgrounds of people that were involved in some aspect of recruitment or implementation, and no community implementation team had the same group of people from an expertise standpoint, all different. So that's a contextual factor. Well, what did we do? This, I'm double dipping here, right? So we're back to that online resource and training package so that we can get people from a variety of backgrounds up to speed and ready to be able to teach this program. It works through a number of different factors that are primarily focused on the recipient or the person that will be delivering the intervention, increasing their capacity, their knowledge, their self-efficacy for delivery, and also likely, we would think, perceptions of feasibility, acceptability, and appropriateness. And so that, we think, would improve the fidelity of implementation of the program when it got into action. So then I'm going to jump to maintenance. This time I don't add in the new box, I just put the arrow up to it. So again, one of the things that I want to really highlight here too is that you're noticing that the contextual factors that we have here generate a number of different strategies. It's very rare in my experience that you have one context, one outcome, one strategy. It's often that the contextual factors cross over and a single strategy might be able to address 2 contextual factors or fit within those 2 contextual factors. Similarly, you might have 3 or 4 strategies that work through the same mechanism. And that mechanism may improve adoption, implementation, and maintenance. So all of this stuff, I'm trying to present it in a way because I think this is one of the easier way to communicate our projects. But knowing that what this is starting to do, and I think by the end, it demonstrates the complexity of the work that we do. But these are, again, to me, the research logic model is a great way to improve communication. And that communication can be used at the beginning of a project, during a project as you're getting results, and after the completion of a project to interpret the outcomes of that project and the processes involved with it. Okay, so here we are, the difficulty in convening community implementation teams. We also, that variety of folks, we felt like having Action Learning Collaborative in Jenny's and Kate's study, or the Core 3.0, this was where the randomization at. In our study, every community gets both things, right? So, and again, it's going to focus primarily on different mechanisms. So we have here, again, remember we're using IPARIS, so facilitation is a big part of IPARIS and perceptions of facilitation. But you can see the different mechanisms by which the Action Learning Collaborative could walk its way through maintenance. But of course, both of those things have influences on each, right? Like having the whole online resource means that I can do it again. I can go through things again. It's accessible, it's ongoing, it's accessibility. So that increases the likelihood of repeated cohorts, which in this study, that's how we're defining maintenance, right? Did you do one cohort? Great, you adopted and implemented. Did you do two cohorts? Great, you're now sustaining. Are you a long-term sustainer? No, but 3 cohorts? Okay, 4 cohorts. So that's how we define it here.
Walking yourself through like what's contributing, what am I thinking? So is it always like written in this left to right format with the outcomes on the right, or?
Yeah, it's a really good question. And I'm not familiar with the process that you just talked through. But the question for folks online was really around, is this, like other types of mapping approaches where you're looking for the key drivers of what the outcome is? And so the other part of the question was, is it sometimes flipped where the outcomes are on the left and other things are on the right? And I would say, I'm sure. Yeah, I'm sure. And, and there's lots of logic modeling approaches that have been out there before this one. And you'll even notice that my preferred approach is to start on the right and work my way back left. And James got some good comments here.
Yeah, I could just share, I'm doing a lot of work with the IRLM and speaking with JD. It's really depending on where are you starting and what do you already know? Do you know what outcomes you want to achieve? And you want to figure out what are my contextual factors. So you can start really where, like we often say, like start at either end, but it's really what do you already know? Oftentimes the IRLM is used to generate strategies. We know where you want to go and you've done some work to identify contextual factors, then you can start to figure out how do we take what's going to either get in the way or help us facilitate this project, and to get to what outcomes, and then how are we going to get there? It's kind of filling in the middle, but it's really, you can use it for anything. If you know your outcomes and you want to fill in the rest, you can do that. If you know your context really well, and then you talk to them and figure out what outcomes do they care about, then you can start to prioritize, like for this case, reach.
Okay. I'm hoping people were able to pick that up on my computer as James talked through it, but it basically said it's really flexible. Right. And it depends on where you're at. And you can really start pretty much anywhere within the logic model. For me, I would say that probably 80% of the projects I do, we start with re-aim. And because we know that you got to be thinking about all of these things, even if your priority is just one. The other thing I'd say is, and we're going to give you that survey that I hope everyone will complete, but is that the mechanisms column here, oftentimes when we're working with our community partners deep in these types of projects, we'll talk to them about why we think things will work, but we often don't even present the mechanism. Like, what's the context we're in? What do we want to do? And what are we going to change from an impact perspective? And then really, to me, our science comes from that mechanisms. That's where we're really contributing mostly, not that the other parts don't as well, but mostly to generalizable knowledge. And so in case anybody was wondering where the individual level re-aim outcomes from our logic model fall in, you can create logic models that would have had building healthy families right in this as one of the areas too, and we could look at mechanisms there. For us, we talk about effectiveness and maintained effect for the families as a function of high implementation quality. If communities are implementing this with high quality, we believe that effectiveness and maintenance for the families will follow. Okay, so I want folks quickly, so I gave, now you have a good, and if you feel like you don't know what an implementation research logic model is, you're wrong because you just saw one, right? So you know what one is. We've got this survey. If you haven't used them very much, that's okay. The survey is going to take you 2 to 3 minutes. If you've used it a lot, I went through the survey and it took me maybe 12 13 minutes. So very quick. It doesn't take very long. And we would love to get as many responses as we can on this. So great. I see people have taken pictures. And of course, because we're scientists, you'll see the QR code again a little bit later. Okay, so some concluding thoughts. I think then I'll open it up for Toby to come back up and see if there's questions. I like to think about outcomes as the priority, right? Like, what is the priority? What's important to science and what's important to your partner? And when you can find a priority that's important to your partner and important to science, that's usually the things that we try and do our proposals around, right? And so but what the outcome is, it's the fundamental measurable metric for impact, right? And so whatever the outcome is that you choose, we want it to make sure that it's a measurable metric that you're able to report out on. And it's typically aligned with demonstrating success since you're trying to meet a priority. Picking a specific outcome framework. You see, we walk through, we're pretty re-aim heavy, me and Toby. You know, I've been working with that a long time. It's, you know, a very comfortable model. I do pull a lot from the Proctor implementation outcome framework, as you could see with our feasibility, acceptability, and appropriateness measures. I don't think it really matters what framework you choose. But you really need to be clear and transparent about why the outcome is the outcome that you're focusing on, why is it a priority, and be clear in how you're measuring it. And I think if we just are very transparent and clear around these things, you're going to be okay. And so again, it's, oh, JD came in with the food. And for those, I apologize for those who are not in Utah, but Buds, if you are in Utah and you're not in the room, I'm really sorry for you. Buds is awesome. Okay, so that's the next thing that I'd say. Oops, there we go. The other concluding thought I'd have here is to select and identify your strategies based on the outcome that you're trying to change or sustain. And so, you know, really be focused on, sometimes in implementation science, we get really excited because we hear about a new strategy. We're like, oh, I want to test that thing out. And it just doesn't fit with the outcomes and priorities that you're doing. So make sure that your selection is being driven by the outcomes that you're trying to change or sustain and are important. Most of your studies that you do like this will focus on one or maybe two dissemination implementation outcomes as a primary outcome, right? If you do a hybrid effectiveness type 2 trial, as I say oftentimes, type 2, 2x2, you're usually testing two different interventions and you have a primary outcome that's effectiveness and a primary outcome that's some implementation outcome. So in those cases, you're going to have two that you definitely will be measuring and trying to change. But it's also important to try and get some level of assessment of the other outcomes that may be important over time. So if you're focusing on sustainability, but you don't assess reach, that's going to be a problem for you later on because of the interrelatedness there. So it's just, trying to make sure that you come up with good descriptive ways to talk through the outcomes. And hopefully you noticed in one or two of the examples I gave, even though I didn't dive very deeply into them, qualitative data is completely fine when you're talking about descriptive outcomes and getting perceptions around those. And so really good qualitative data and mixed methods approaches are there. I just talked about this, so we didn't present much on the interrelationships in outcomes, but I really think it's a great area of future research. One of the things that we ended up cutting from here are advanced metrics. So both re-aim and then our Riley article, we present a number of combination metrics for individual level attributable impact, things like organizational level impact, over time, cost per unit of adoption by implementation. So there's a lot of different ways that we could be looking at. And again, very complex ways to combine stuff. But at the end of the day, I think eventually we're going to need to get there because, continuing to be reductionistic is going to miss a lot of the bigger picture. But these are great areas for future research. And with that, we will open it up for questions. And Mike, how did I do on that? Is he still there? Well, and thank you to Toby's going to come up here. Maybe we'll switch back to the owl. Okay, so I will mute and we'll open the floor for questions. Remember, you guys can see QR code if you missed it.
Yeah, thank you. That was really good. Do you have any questions, general questions, specific questions?
Just off the bat with what you're saying about researching these different kind of correlations and everything, then you're talking about researching that for your specific study, right? And then the implementation size of that, or the logic component itself. Got confused now with the survey.
Well, I think, so yes, so the question is around were we talking about research in general or research around logic modeling? And I think for us, we're talking more generally about things. I think the implementation research logic model is an outstanding tool to communicate the things that you're doing and to plan. So I think that's really good, but it's also an area that we can research and see how are we doing with that logic model. How are there better ways to use it for communication? Are there better ways to use it with community partners and those types of things? And that's what the survey is going to be about.
Okay, yeah.
And just to, I think that the beauty of that is, you get to do it with your community partners. That's something we're doing on Global Health now, where the end goal is to build logic, like implementation logic module. But what we did, we have our outcomes, then we start with the contextual factors. We don't know what we're doing. So we discussed that, what are the barriers, what are the facilitators to things. Then at another meeting, they do what are the strategies to address the barriers. And then we talk about it, and then prioritize the strategies. Then we talk about the mechanisms. At the end of the meeting, then we show them this is what you've been talking about, the logic, so they're able to see. So it's really good that you can do that with the community.
Any questions online? All right, excellent. We didn't plant these with that.
With kind of, defining what mechanisms are and what outcomes are and what a strategy is, looking at activities and actions, it seems like that falls under strategies. And then I feel like we're talking mechanisms, is that the goal? And then the outcome is how you measure the mechanism as a goal, or
the mechanism. So the question is around, I guess, can people hear on the owl if everybody's talking to them? I don't have to repeat.
I think so.
Okay, so the question is really around the mechanism. And so first, I'm going to start with your kind of actions and what was it, activities and actions or kind of strategy. Yes, I think that's absolutely a good way to think through it. The mechanisms, I was trained as a behavioral scientist, and so I think of mechanisms a lot like mediators. But when we talk about mediation, we're usually talking about a statistical testing of, this intervention makes this factor, like, in my world, self-efficacy, right? So I create a social cognitive theory intervention to target increases in self-efficacy, and that self-efficacy is intended to be a mechanism to improve physical activity. And then I'll do my study, and I'll do then a mediational pathway to see if people that got the social cognitive theory saw greater increases in self-efficacy than those in control. And then I'll see if they also got more physical activity than those in control. And then I will test to see if the relationship between self-efficacy and physical activity is, if it explains the variance between the two intervention conditions. And so it really is about a causal pathway. That's what we're thinking about. And mechanisms, yeah, I have, gosh, we had a good definition slide in the last one that I'll try and send out, but does anybody have a better definition for mechanism beyond being a causal factor? That it's not the outcome, it's definitely not the outcome. And it's probably not the goal. And as I said, like, increased implementation team capacity could be something that is, a combination of their self-efficacy to deliver and their knowledge, right? So we could create a capacity measure there. And we would design intervention to increase knowledge and self-efficacy. That's their capacity measure. And we would then say, we would think that the changes in implementation quality were a result of the capacity that we developed. And so is it a goal? I don't know. To me, it's just more about the science, that if we have a strategy that stops working on the outcome, I'd want to look at the mechanisms to see if the strategy is actually influencing the mechanisms we think it's influencing. And if it's not, it might be that the strategy is no good and not that the mechanism isn't any good.
Yeah, that helps.
I don't think it helped, but you're very kind. You're very kind. Other easier questions? Heather.
I kind of have, well, I guess thinking back to like basics, like the healthy families, the Nebraska study, or when you had showed before, like that was pretty clear that reach wasn't being hit. There was other factors that showed it was, effective, probably adoptable, stuff like that. What do you do when nothing is clear? Like, how do you know what to focus on?
Yeah, that's a great
I don't know if
question.
that's easier.
That's actually, I feel like that's a super easy question. So the question is that if your data is not really necessarily showing you which dissemination or implementation outcome should be prioritized, or you're not quite sure the direction you go, this is where I always lean on our partners, because you're working with a system or an organization or staff that they have priorities. And even if things aren't very clear, that's when their priorities are most important. Is okay, well, what's your priority? Well, great. We don't really know whether this thing is working. So let's kind of talk all around the priority. And if the priority is reach, then we can come up with, doing things like, group concept modeling, where we just start to brainstorm. Well, what are things? Why aren't we getting the higher reach? And then start to build strategies based on that. So I always, lean back to what's the audience that we're working with and trying to support, and then aligning what we do with what their priorities are. I would say that it's not very rare that we don't know what to work on. It's not very common that we don't know what to work on. I think that, usually you're coming together with priority of the partner, expertise of the team, and if you've had that match go pretty well, it's straightforward. One thing I've been thinking about too is that, maybe we need, first of all, let me ask you guys this. Today, we hope that you got from this a very good idea of what dissemination implementation outcomes are. We hope that you got that. What we didn't do was tell you how to measure them. And so I'm thinking that it might be a point in time that we should come up with a workshop that focuses on measurement of these outcomes and how you operationalize things. And I'm not seeing the people online. In the room, we're getting a lot of nods there. So that would just be one that we put on our list of workshop ideas. Okay. We good?
Even do have another.
Oh, you do have, hey, Hannah has another question.
With, I guess coming from a behavioral background as well, like, if there is no buy-in, there is, community partners are not agreeing on outcomes, there's no clear outcomes to be, or desired outcomes. And then there's intervention of change, right? Like, do you think, is that its own change management structure, or can you also use the logic model there?
Yes. I think you can do both. So if people didn't get, this is how I'm interpreting the question, is that if you can't even get agreement amongst partners on what you should be doing and what the priority should be, or that there's not a priority for the intervention that you think would be very, very helpful for a given community. I think those are all subtly different things, right? If they can't agree on a priority, then I would go to our community collaboration and engagement team. And I would say to them, we need to do a prioritization process with our partners to really figure this out. Because there is, if there's no priority, then you gotta kind of wonder about whether this partnership is really needed, right? And so that's one thing I would start with. So I would go more towards engagement science and figure out, okay, what is this group here for? What are we here to do? And come up with, whatever that is. And then the other one is, more around, if you have an intervention and it's not their priority, well, then that's just not the right thing to be doing in a collaborative approach. The one caveat I'd say to that is that, what if, there is just a huge health disparity in a given thing, in a given group of people that just aren't prioritizing that, and the organizations aren't prioritizing that. I don't know if it's the old white colonial guy in me that feels like, oh, we still got to do something, but I do think that there's opportunities for intervention to increase maybe the culture and groundwork for dissemination, so that there's things that we do that are focusing more on contextual changes, like how do we actually change context, so almost flipping the context around a little bit into a mechanistic place. So it's a hard thing, but I think in my experience has been when working with partners that you're having a tough time coming up with a priority, then you just got to wonder if this is the right time to be working together on something.
Very community engaged approach. Well, I think often, unfortunately, the tail wags the dog a little bit with RFAs and funding opportunities, telling you essentially, we know the general problem is that communities are not adopting the PPP, for example. That's a pretty general problem. So you're probably going to have to write a grant around that, but then still work with your community partners to make sure that you're prioritizing what they really care about. So there is a little bit of that grantsmanship. What are the reviewers going to want to see versus, it might not always work someone line, but I agree with Paul. If you can't find common ground, that's an issue.
Yeah, and if you guys couldn't hear on the owl, JD was saying that there's also some opportunities around grantsmanship, that sometimes it's, how we're writing our grants might not be directly in like what the primary outcome is, might not be right in line with the priority, but you might be able to achieve that primary outcome while also meeting the priorities of your partners. And he told me it was a very community engaged approach with me, which I take as a high compliment. Okay, now I think we're done. Thank you, everybody online, for joining us. Thanks for everyone in the room.